So we'll get into a little bit of a broad topic today, kind of some of the most common topics and conditions that we see in the foot and ankle world. So a little bit about myself. Kelly kind of hit on some of it, but born and raised here in Wisconsin, up in Shawano near Green Bay. UW-Stevens Point for undergraduate degree, Des Moines University for podiatry school, and then again Ascension and some of the Aurora facilities for residency over in Milwaukee area. Started here December of 24 with Stoughton. Very happy to be here. It's been a nice transition for myself and my family. I have a wife and an almost 3-year-old daughter, so been fairly busy outside of work as well. So if you haven't been in clinic or don't know me, I kind of have a patient first philosophy. Really listening to the concerns that you have when you first come in, really making sure that you feel heard and there's time spent in clinic. That's one of the benefits here at Stoughton Health as well. A little bit of extra time to really work with folks and make sure that your concerns are heard and that you have this sort of team effort and this personalized approach really to everybody that comes through the door. So just kind of, top-down view of the foot. It's a very complex structure. So 28 bones, 33 joints, 112 ligaments, 21 intrinsic muscles. So you can imagine when you're on these all day standing, or if you're, even sitting and you're very active throughout the day, how things can begin to hurt after a period of time. So again, just kind of a broad view of some of the signs, symptoms, treatments associated with these. And again, these are some of the most common things that we see in foot and ankle. So bunions, plantar fasciitis, and just Achilles pain. We'll hit on a couple of different concerns for the Achilles today. So, you've probably heard the term bunions. You maybe look down and this looks like yours. So what are they? It's prominence typically on the inside of the foot. At the big toe joint. Big toe starts drifting over to the second toe. And it's also known as hallux valgus or hallux abductovalgus. I apologize if you can hear upstairs. That is my 3-year-old running laps. Some signs and symptoms of bunions. Typically irritation at the medial bump there. You'll get irritation from shoes. Even sandals sometimes are difficult to find wide enough to accommodate that. Pain, numbness, burning, typically pain at the joint. It can also be pain at the second toe, as stated there later down the list. The numbness and burning typically occurs due to a nerve that supplies sensation to this portion of the foot, and it can get compressed. So just as you can see the irritation on the skin there, you can irritate the nerve directly underneath, and sometimes people, their main concern will be either a burning or a tingling sensation over that bump. People tend to get a large callus. This site specifically is known as a pinch callus. You'll basically develop two sides with a fissure in between directly underneath that big prominence. And a lot of that is, again, just due to the shape of the deformity as well as the toe starting to drift over, and that rotates as well. Again, difficulty fitting in shoes is the main concern for people. You can naturally see here on the bottom, if you progress from your left to right, you can see naturally how that foot widens quite a bit. And if you look at the midfoot here, where people tend to say, oh, I need wider toe or I need wider shoes, you can see that stays relatively consistent throughout the midfoot. It's really the forefoot, this portion out further, that becomes much wider. And, so something like a double E or even a triple E doesn't necessarily accommodate that and can actually make it too loose at the heel. And then again, pain at the second toe. As this big toe starts moving it over, it has much stronger tendons and force attached to that toe than the lesser toes. So you start bullying the second toe up and out of the way, and you can get what's known as a crossover toe like this. And this can lead to a lot of pain underneath the toe itself, just due to the buckling and pushing down on the head of that metatarsal, the bone right behind the toe. A lot of people will complain of either pain directly at that joint or development of a large callus underneath there due to the increased prominence underneath that second toe. So what causes bunions? Genetics, things like soft tissue laxity, things like Ehlers-Danlos. Down syndrome has been shown to have a higher prevalence. These are considered hereditary in a sense that, some people are born with them. You maybe know somebody who had pediatric bunions. So it's not always shoe driven, but it certainly can be. Hereditary as well. You've probably heard of people who, their grandma had it, mother had it, they have it. So there is a hereditary or a genetic component to it as well. Poor fitting shoes, again, if you have high heels, you're putting a lot of pressure on the toes, or if you're forcing the big toe over into the second toe, you're more likely to cause a contracture of the tendons in the joint over on that side. That kind of contributes to it, or at least can expedite the development of it. Flat feet is more so due to changing the biomechanics of where the force goes through that joint. So it tends to be more on the inside of the big toe or the outside, if depending on how you're looking at it, the medial aspect of it, where the big prominence is. As that toe moves over and you have a flat foot, you again keep walking on the side of it and you force that toe over further, similar to how poor fitting shoes do that. And then disease, inflammatory arthritis, such as psoriatic arthritis, rheumatoid arthritis, they cause inflammation and damage of the joints themselves. That damage can ultimately lead to significant bunion deformities. So what am I looking at? When we get an X-ray, you've probably gone somewhere and you've had an X-ray done. So what am I looking at? So realistically, on the left, you'll see this normal foot. What we're looking at is what's known as an intermetatarsal angle, and that's the splaying or the distance between these first and second. You can see here how significant that angle is between, somebody with what I would call a severe bunion over 18 degrees and somebody who has a normal foot structure under 10 degrees. The other thing we're looking at is how much tip there is of the big toe in relation to the axis of this first metatarsal here. So the further tipped this is, the more deformity there is, and the more likely you are to develop arthritis. Because if you were to look at this, you're really only operating on about 50% of the joint, which again, you start having this similar or even in some cases greater force going through that toe because of how it's tipped over to the side, and you can actually develop quite a large erosion to the joint over here. So these are just some of the things we're looking at. These two little sort of white dots that you can see. This is another portion that we're looking at. When we're looking at correcting these basically act as pulleys for the tendons that go to the big toe. So when these come off to the side, again, we know that there's a rotational aspect as well as the splaying between the two metatarsals. So that's sort of the third fact that we're looking at on X-ray. So what are some treatment options? So again, as discussed, wider toe box shoes. If it's something that doesn't really bother you within the joint, it's more just irritation from tight fitting shoes. A simple conservative treatment option is finding the wider toe box. And again, it's not wider shoe as in like a triple E or anything like that. It is, when we say wide toe box, we do mean the design of the shoe. So you can get both of these shoes in the exact extra wide width, and you're still going to have that shape at the toe. And this one is still going to have this shape at the toe. So what we're referring to is more the actual design of the shoe itself to accommodate this, not necessarily the quote extra width. A softer toe cover, so the mesh over top of the toes in the front of the shoe is more accommodating than say like a leather or something that's got more seams. Like leather seams are very stiff. There's not a whole lot of give to that fabric. Then there's also offloading pads. Here's a couple different options where this one has a spacer between the first and second toes that helps get the big toe off of the second, and it's also got a gel sleeve that goes over to sort of pad over that big prominence. This is a little bit more robust, and these do also come with a spacer between the first and second, but again, you can appreciate that gel pad that's within here. The other option is physical therapy. If it's a younger kid, if it's something where you're maybe not looking for surgery of any kind, or if, having a spacer in between your toes isn't something that you can tolerate just from a sensation standpoint, or the type of, shoe wear you have to wear, you can use some level of physical therapy. It does not correct that splaying between the metatarsals, but it does allow you to be able to abduct your big toe away from your second. And then ultimately surgery. Orthotics, again, if you have a flat foot that's helping to contribute to that, orthotics can certainly help. Again, nothing outside of surgery is going to actively correct the bony deformity that you have, but there's certainly things that can accommodate if surgery isn't an option, or you're just trying to get by. Surgical options, there's all sorts of them. Typically, when we're talking about bunions, there's really two main things we're looking at. One, we're looking at either doing a lapidus procedure, which would be fusing the joint back here. This is ultimately where your deformity stems from. There's an obliquity to the joint in a lot of these cases that causes this to start sort of tipping off to the side. The other option would be something like this, which is more of a cut through the bone further out, and then some type of fixation. So there's a 100 different bunions that you could perform. Typically, the two that I do are some variety of this, a Lapidus procedure, depending on if you have arthritis or any sort of instability, true instability back here, or something along the lines of this. And this would be known as a minimally invasive or percutaneous bunionectomy. And these up here are the planned incisions for these. So the reason why we would do something like this is because you have a couple of small poke holes. So these screws are inserted through small poke holes. The cut through the bone and the shift of the bone is done through a small poke hole. So there's a lot less swelling, a lot less issues as far as post-operative pain. There's the other option that we discuss a lot of times and is included with most bunions is also this little wedge that we can take out of the big toe. So a lot of times after you have this full correction from the actual bunion or the splaying between, a lot of times that big toe will still touch the second and will add sort of if you take a pizza slice effectively, I tell people out of that phalanx there, you'll effectively tip the big toe away from the second toe and then a screw sits across it. But I try to do things as minimally as possible. It really does help with postoperative pain and swelling, but sometimes you do need these larger incisions depending on what we're trying to correct. So moving over to plantar fasciitis now. So, just kind of general overview. What's the plantar fascia? It's a fibrous band that connects on the bottom of the foot, connects the heel to your toes, and it has 3 segments. So there's a medial band, a central band, and a lateral band. Most people, when they have pain associated with this, will be at the medial and central connection here, just off where it connects. Very rarely do people have lateral band plantar fasciopathy, but it does occur. So this is the most common cause of heel pain. Most people that come in that have heel pain, this is on the differential immediately from the start. So this is typically a degeneration and a disordered repair. So these views here are an ultrasound of the plantar fascia. And you can see this is an asymptomatic thickness here. So we're kind of looking at the distance between these 2 white lines and just kind of generally how this fascia looks. You can kind of see these white lines back and forth. This is a normal plantar fascia. You can see this one here, quite a bit thicker, and it has a lot more dark tissue in it, which is more degeneration associated with that tissue itself. So the one on the right is certainly painful. And then up here, you can see what can happen long-term with that degeneration is some people have a propensity to actually develop calcifications within the tissue itself after long periods of inflammation and then the degeneration that follows. So signs and symptoms, again, this typically is a sharp stabbing pain at the heel or the arch of the foot. Typically, this occurs after long periods of standing or long periods of activity. We'll also hear a very common symptom of your first few steps in the morning or your first few steps after getting out of a long car ride, those types of things. And again, it tends to be at that just off the heel on the bottom side, and that tends to include more of the central and the medial band. And some people will actually have some significant swelling to the heel if it's more of an acute or just recently happened event. So what causes it? High and low arch foot types can certainly have plantar fasciitis. Equinus, this is one that's been really well studied. A tight Achilles tendon. Basically, what ends up happening with a tight Achilles is that you don't have the pliability within the tendon, and so you tend to put more weight out on the front of your foot. That transfers more weight into that plantar fascial band that's trying to help maintain the arch, and in turn puts more stress into it and ends up leading to those small tears and ultimately that degeneration. Abnormal walking patterns can certainly lead to plantar fasciitis. Overuse, runners, I like to not tell people that they're doing too much. You always have to tell them that they're just under recovering. Especially with runners. So, overuse is certainly a possibility as well. Obesity, the more weight you carry around, the more stress you're putting through the joints, the more stress you're putting through the tendons and the ligaments. So that certainly makes sense. And then again, standing for long periods of time. We're really not meant to stand in one place for extended periods of time, being that we are on 2 feet rather than four for most of the animal kingdom. So we're really not meant to stand, especially on these hard surfaces, for extended periods of time. Treatments, there's a lot of them. Activity modification. So again, if it's something where if you're standing at work for a long period of time, activity modification could be something as simple as anti-fatigue mats. It could be seeing if you can do a portion of the day seated or at least alternating standing, sitting. Stretching, massage, that coincides with physical therapy. There's a lot of good stretching exercises. Again, that goes back to that tight Achilles tendon, tends to drive a lot of this. Same with this night splint, which is up here on the right. So this is something you would sleep in. And the ones that you would want to look for, one is either called the Strasbourg sock or this one here. But basically, they pull they stretch the Achilles tendon, but they also pull up on the big toe, which activates your plantar fascia. So you effectively get a double stretch overnight while you sleep. Night splints have actually been shown to work quite well for people with plantar fasciitis, especially when it's early on. There are some advanced therapies. This is shockwave therapy here. Shockwave therapy is used in a lot of tendon and ligament pain and pathologies all over the body. This is not a insurance covered modality. It's not something that we currently offer at Stoughton Health, but there are a lot of chiropractic and rehab places in Madison that do offer shockwave therapy. It tends to work quite well for people, but again, it's not covered, so it's not normally the first line that we offer. There's certainly injections. Corticosteroid injection tends to be the first line after you've tried some of these other options. If we're working up the ladder of orthotics, stretching, activity modification, typically injection would be next in line for that. A lot of people do very well with an injection. For some people, it completely eliminates it. Some people will have recurrent, just depending on the type of work they do. Sometimes they'll come in once yearly for an injection to the site. It kind of depends. Everybody's a little different with that. And then ultimately surgery. This one specifically here shows what we call an endoscopic release of the plantar fascia. So this is a small camera and a little blade that we stick into the foot through a very small poke hole. And you cut a portion, about 50% of the plantar fascia, that alleviates that tension. And basically it turns it from this chronic inflammation and this chronic degeneration into more of an acute, and we can sort of control and protect it from there. Some treatments, if you've had one of these in the past and you still have pain there, and you have equinus or that tight Achilles tendon, we can do this exact same procedure through, again, a small camera or even a mini open, and do basically the same release, but of the gastroc tendon, basically the one of the two that create your Achilles tendon, to increase motion and more pliability to the back of the leg, to decrease, again, how much force you're putting in the front of the foot. Oops. Going on to Achilles pain now. A lot of different styles and flavors of Achilles pain here. So we'll kind of hit tendinosis/tendinitis, Achilles ruptures, bursitis, insertional, calcifications, and also Haglund's deformity. So Achilles tendinitis, this is an acute inflammation of the tendon. Tends to begin with swelling, pain, and occasional stiffness. These tend to follow increased activity or overuse. We see this a lot in the spring and summer when weather gets nicer. If you've been kind of laying low throughout the winter and you suddenly increase any sort of uphill walking or hiking, or maybe you went on vacation, you did a lot of walking, depending on the footwear. If you were in sandals, you went somewhere nice and warm, you had sandals on, did a lot of walking. Plantar fasciitis is a possible, as well as the tendinitis to the Achilles tendon. And these can lead to tendinosis, which is more of the degeneration rather than that inflammation of the tendon itself, or even frank rupture, depending on the activity. So Achilles tendinitis treatment tends to be an activity limitation. Things that aggravate the tendon, certain positions that aggravate the tendon are things that you'll want to discontinue, at least in the short term, to decrease the amount of stress and inflammation that you're putting into the tendon. Immobilization or protected weight bearing. that tends to be if you come in and it's so painful that you're having difficulty putting any weight into it. Typically, for me, people go into a boot just to protect range of motion, and the boot naturally has a little bit of a rocker bottom, so you're not using the tendon as much. And that's done typically in conjunction with NSAIDs or a steroid pack, a short-term steroid pack, just to really control the amount of inflammation and pain that you have to the tendon. From there, we work through physical therapy. The Alfredson protocol is one of the ones that's been most studied for Achilles tendonitis. It's what's called an eccentric exercise, where you're focusing more on the controlled lengthening of the tendon. So if you think of like if you did a bicep curl on the way up, that's a concentric, and then on the way down to a normal straight arm would be the eccentric. So again, we're working on an eccentric type exercise for these tendons. Basically, what we're trying to do is choke off the new nerves and the new blood vessels that are trying to get into this, and that's really what's leading to the pain and the kind of this chronic inflammation, this continued inflammation of the site. Again, advanced therapy, shockwave therapy, laser therapy can work well for these. We do also injections for tendons in the foot and ankle. Things like PRP, platelet-rich plasma, hasn't been shown to be that effective, but for some people, especially athletes, it can certainly get them back a little bit sooner. Night splinting, again, making sure that the tendon's stretched and pliable for when you get back to those activities. And then again, ultimately surgery. Surgery for something like a tendonitis, or which has gone to more of a tendinosis, which is that degeneration and that really big thickening or scar tissue that builds up. If it's combined with equinus or that tight Achilles tendon, we tend to do a lengthening, that gastroc lengthening we had talked about with the camera. So lengthen to decrease the equinus, and then go in and actually remove a lot of the scar tissue of the tendon itself. That tends to be done in conjunction with an amniotic graft to try to decrease the amount of scar tissue that develops from that as well. And the picture here is, it's again referring to the calcification within a damaged tendon. Achilles ruptures, these can be partial or complete. Most people will feel or hear a pop. A very common descriptor is feeling like they got kicked in the back of the leg. Very common in basketball, soccer. Um, Felt like they got kicked in the back of the leg, turn around, nobody's there. There's a variable degree of pain. These surprisingly aren't all that painful for a lot of people. But it does lead to weakness. Again, the Achilles tendon is the strongest tendon in the body. It can support up to 7 times your body weight when sprinting. So naturally, you would have some level of weakness associated with a rupture of that tendon. These tend to lead to, a lot of swelling in the area and bruising specifically because of how vascularized it is further up. And then a lot of times what we'll see and how we can see these without MRI or further imaging is really this dell or this divot. So naturally, if you see, a gap in the tendon like this, if you would run your finger over that, you can effectively feel that there's not a whole lot of tissue over most people's Achilles tendon. So it's actually quite easy to feel that. This one here specifically is more looking at an avulsion fracture where the Achilles attachment has maintained to the bone, but the bone itself has come off. This is a bit rarer. Tends to be more so from either an injury or a hit to the back of the heel itself. These types of injuries tend to be more on a fully or a dorsiflexing. So if you're back pedaling and you go to put your foot back and your momentum's going and your foot is coming up into dorsiflexion, that tends to be when we see most of these ruptures. Similar with basketball, you've probably seen. So again, diagnosing complete tears, mostly clinical. Again, you can feel that deficit there. Otherwise, ultrasound or MRI, if it's a questionable tear, or if we really want to, if it's up further where it's a little bit less cord-like and a little bit more sort of fanned out as the tendon splits into the two different aponeuroses, or basically they fan out into two effectively flat tendons higher up here. So here's an MRI again showing this dark cord all the way up is that nice normal Achilles tendon. And then again here you can see thickened Achilles tendon and then complete disruption in fluid where that would have been. This is known as the Thompson squeeze test. So this is one where squeezing your calf at rest will cause plantar flexion of the foot. And again, when you have a ruptured Achilles tendon because you've lost connection here, you'll lose the ability to have that motion when you squeeze the calf. So that's another sort of clinical exam that we look at. And then again, certainly, you know, visualizing side to side. The other thing that we're looking at here is what's known as the matless exam, where you can see natural resting plantar flexion. You can see the toes a little bit further. You can see more of this foot. And then this is, again, you've lost some of that. You've lost that tension to the tendon. So the foot tends to stay more of in a neutral position when you're looking down the end of it. So partial rupture treatments, these are rarely surgical. These are basically put into a boot in plantar flexion. So we're basically putting heel lifts in a big cushioned boot to force the two tendons back together by keeping the foot in that plantar flexed position. And then you follow this Willett's protocol or something, similar, basically where it begins with weight bearing. You sort of work with physical therapy on strengthening. Over time, you start removing heel lifts, as you can see around that sort of 6 to 8 week mark. You start removing heel lifts. Again, what we're trying to do is have the Achilles tendon start healing and then remove heel lifts to get your foot back to a neutral position effectively. What can happen for neglected Achilles ruptures is, again, when there's that gap, it will heal. You will develop scar tissue between there. And a lot of times it's difficult to even feel or see if you've had a rupture that was neglected. But what most people will have is weakness because that tendon is now much longer than it used to be. So you've lost that natural tension within it. So you lose the strength associated with that. Complete rupture treatments, you can follow non-operative Willett's protocol. There's actually a lot of new research coming out, and specifically in Canada, they're performing surgery less and less. Most people that are active, most people that are, under 50, 60-ish, I still recommend it. It tends to be a quicker return to activity and has less risk of re-rupture when you control how the tendon comes back together rather than letting the body do it on its own device. So these are really the two, open or mini open ways of doing this. So this is what's known as a Krakow stitch. So you kind of go up and down and tie them back together. This is a specific one known as a mid-substance speed bridge. So if you remember what Aaron Rodgers had, that would be this one on the right here. But basically you do the same sort of stitching up on the top part of the tendon, and then you have anchors down here in the heel, and you pass the suture from this side through the tendon and into the anchors. This has a higher pull-out strength, and you can get people back to doing activities quicker with this because it's less risk of re-rupture even compared to just end-to-end repair where you're relying on the knots of the suture rather than the actual strength of the suture itself and anchors. I tend to do more of a just mini open procedure with end-to-end repair. I've seen people have complications with the anchor sites and pain. The back of the heel is a very sensitive area. So I try not to violate that with anchors if I don't need to. And then Achilles insertional calcific tendinosis, long way of saying basically you have calcifications at the actual insertion of the Achilles tendon, and then a Haglund's bump. So these tend to be pain at the back of the heel, stiffness in the Achilles tendon. Some people, as you can see here, will have a real obvious bump at the back. And a lot of times, as I said earlier, the back of the heel can become quite sensitive, and shoes that fit properly have a good snug fit on the heel to maintain the foot. Some of these you'll see more of a soft versus sort of a hard bony prominence. And that kind of gives you a little bit of an idea of if it's more due to the Haglund's deformity of the bone itself, or if it's more squishy, if it's more due to a bursa or a sac of fluid that your body has built up to try to protect the area. So Haglund's is congenital. It's just how your body happened to develop that bone. Some people have a larger bump than others. Some, it tends to be more pointed than round. This Achilles insertional calcific tendinopathy is basically a consequence of just a chronic traction or a tight Achilles tendon. The same thing can happen with the plantar fascia. You've probably heard of somebody that's mentioned heel spurs before. It's basically your body is trying to build up strength where that tendon or ligament attaches to bone, and it does that by depositing more calcium essentially and building up bone at the site. So some people will get a quite large spur on the back of the heel. Spondyloarthropathies cause these enthesitis. Basically an enthesopathy is the spur. It's a fancy name for the spur, but basically just inflammation where tendons attach to bone. And then symptoms may be worse with rigid back shoes. I've had quite a few people come in that they basically resort to open back sandals year round because they just can't tolerate anything touching the back of the heel. So typically, if you're looking at early treatments for these, it's open or soft backed shoes, trying to decrease pressure on the back of the heel, offloading gel or horseshoe pads to try to, again, direct pressure around the bump rather than directly to it. Anti-inflammatories, ibuprofen, meloxicam, naproxen, even steroids, short-term steroids work well. Physical therapy, again, these are a consequence of having a tight Achilles tendon. So certainly stretching exercises can be beneficial. And then ultimately surgery if conservative treatments don't work out. So there are a lot of surgical options for these. So here on this patient on the left, again, none of these are any of my patients. These are all just found online images for educational purposes. You can see they have this big spur on the back of the heel. Similarly, they have a small one on the plantar fascia as well. But this would be the Haglund's bump. And as you can see, as the tendon tends to come up from where it attaches in this middle third here, as it comes up, it naturally runs into this bump. So if you have a smaller bump or it's more rounded, you tend to not have any pain associated with this. If it's a larger or more pointy bump, then that's where people tend to get pain and can develop that little bursa even back here. This is an open procedure where basically you don't have to every time, but most people do remove the Achilles tendon. So you have direct access to both the spur and the Haglund's deformity. And then this is anchored back in. You can barely just make out this lucency within the bone. That's an anchor to reattach the Achilles tendon. I tend to not do these ones specifically, especially if it's open. Again, the back of the heel can be very sensitive, and this procedure has worked well for a long time for a lot of people, but I do see enough people that have scarring along that incision site. And again, it's a larger incision site to be able to access all that. And then again, you're relying on reattachment of the Achilles tendon. This is known as a Zadig osteotomy. This is more the procedure that I do for most people. What I'm also measuring is the length of the heel in the entire calcaneus versus the top portion of it. People that tend to have pain back at the Achilles and with the Haglund's bump tend to have a longer top portion of the Achilles or of the calcaneus versus the overall length of it. So this procedure initially was developed to take a wedge out, and as you bring the heel forward, you decompress the bump. And because it's coming up slightly and in, you decompress a little bit of the Achilles tendon. So people actually get quite a bit more range of motion without having to do any sort of cut up here to release the length of it. These types of procedures, the Zadig, I do through a couple of small poke holes now. So this is probably one of my more common procedures that we perform on a monthly basis. But basically, it's a small incision on the side of the heel. It's a small burr that we go in and cut this wedge out with. And then typically the way you would fixate that is 2 screws inserted from the back that would go from the back of the heel into the heel bone. This procedure for me is about 2 weeks of not putting weight on it, mainly for these 2 incisions on the back, and then walking right away in a boot at 2 weeks, typically in a shoe at 6 weeks. So that's what I have. I think we'll go through a question period here. I'll just preface the question portion by saying if it's something very specific, this isn't an alternative to, a formal diagnosis or an office visit. So happy to answer questions here if you have them. And if it's something where you'd like to come in, I'd be happy to see you.
So you're welcome to hit that chat button on the bottom and put something in. I think it'll come to me and I can read it out loud. Or Dr. Lind, if you want to look at the chat in case it comes to you.
Yeah.
And before anyone types in, I'll sneak my question in. And I'm sorry if I missed it in the beginning on the bunions. It's my understanding you can get bunions on the outside of your foot, not just the inside, correct?
Correct. Yep. Yeah, it's something that we would refer to as a bunionette or a Taylor's bunion. It's similar in the sense that it ends up being. I'll kind of go back to the X-rays here. It ends up being either an enlarged head of the metatarsal, increased splaying between the fourth and fifth, similar to how we look at the splaying between 1 and 2, or some people will naturally have a bowing associated with that fifth metatarsal that ends up leading to a lot of pain underneath or on the side of the outside of that joint there. The treatments are similar in a sense that you're trying to offload that site. So again, horseshoe pads or these types of deals exist as well for the outside. And then again, surgery is similar. So it basically would involve, again, it can be done similar to this through a small poke hole where you cut the bone here, shift the head over, and then for me, I do a single screw sort of in that fashion there. And that decreases the big prominence here. And if need be, if you have a big callus or a wound on the bottom, we can also elevate that slightly to take some of that pressure off the bottom aspect of it.
Okay. All right, so I have one here that says, can you address footwear for plantar fasciitis? For instance, it is beneficial to move to a zero drop shoe as opposed to cushioned shoe like Hoka. How would someone safely transition to a zero drop shoe?
Yeah, it's a great question. We're seeing more and more of this. I think as more people have access to information on the internet and that we're seeing a lot more of this zero drop. There's been a big push of, barefoot or minimalist type shoes. I think where minimalist and barefoot type shoes and zero drop shoes tend to have the biggest win right now is they have the best shaped forefoot shoes. So most of the barefoot shoes are going to be something along these lines. They do make more cushioned ones. And I would say it depends on what your day-to-day activities are. If you're somebody who stands a lot all day or you're constantly doing a lot of walking on like cement or, hard flooring, a low cushioned shoe is probably not the best idea. I usually tell people that if you are going to start transitioning, there is a ton of information online. As a podiatrist, I don't normally recommend it because most people that I see benefit from having some level of cushioning, mainly because we're mostly heel strike walkers and that we tend to hit heel first with a very sort of rigid, extended knee. You will change how you walk when you transition to minimalist shoes or, zero drop shoes. Just due to the lack of cushioning. But zero drop, what we have seen is because it causes more stretch in the Achilles tendon. So specifically to your question, would just be going slow. You may develop some tendonitis within your Achilles tendon, again, because it has a little bit more stretch to it, but not having that bit of a lift at the heel. But I would just caution if it is truly minimalist or barefoot type style of shoes, I would caution going slow. But nothing wrong from my point for a true just cushioned zero drop, as long as it's a slow transition and you watch for things like Achilles tendonitis.
Okay. Do you ever encounter issues with pain issues on the top of the foot? What are some common issues that occur with pain on the top?
Yeah, it depends on specifically where you're referring. Most of the pain on the top of the foot, if you're kind of concerning over, the metatarsal area and sort of the forefoot, midfoot, those can be stress fractures, or they tend to be more arthritis type symptoms. They certainly can be tendonitis to the extensor tendons. If you've got a tight ankle, and you're trying to bring your foot up, those extensor tendons on the front can overwork and develop a tendonitis. But Typically, if it's more along the front or sort of top mid of the foot, that tends to be more of a stress fracture or an arthritic type symptom. Just a couple direct messages, specifically about where to find spacers and gel sleeves. Unfortunately, they're niche products as far as they're not at McGlynn's, they're not going to be at Walmart or anything like that. You might find certain low variety of them. Typically, that's something where it depends on what exactly you're looking for. A lot of times, I'll either give patients a printout or kind of show them specifically what we're discussing. Some people have different preferences on sort of how much cushioning, how much is over the foot. There's hundreds of different bunion spacers and gel sleeves that are out there. So typically, I just tell people Amazon, or we'll print out a sheet if there's one specifically that I think would work better for someone. But yeah.
There's another one, speaking on the topic of bunions. What actually is a bunion? Is it bones moving?
Yeah. So if we, kind of go back to this one again, it's this, what you're looking at here on the top view is just the big toe moving over and this increased bump here. So this isn't a growth, so to say. Some people will think that this is a bony growth that happens here. It's actually just a consequence of, it's just this here. It's your normal first metatarsal head. It just happens to be that it's moving further away from the second. And as this continues to splay out this way, and this sort of red line here tips further and further down, you just get more and more prominence here. The reason why this big toe is an issue with that is because the joint is continually moving this way because of the deformity. And your tendons that attach to the big toe are still on this side of the joint. And so they contract and they still pull the big toe this way. Whereas you can see in a normal foot, when the tendons pull, again, these are basically acting as pulleys for the tendons, that big toe moves directly over the joint. And this is why, this is a normal functioning foot. And this one isn't, because the tendons are trying to pull the big toe up, and it's basically pulling it into a space where it's not meant to be. And the actual axis or apex of that rotation is further over here.
Do you treat ingrown toenails?
Yeah, absolutely. It depends on the variety that you have. If it's something that's recurrent and it causes pain, if it's been multiple infections, typically we see in for an initial evaluation. If it's really infected, and you haven't been seen before, typically we put you on antibiotics and then we have you come back later for a procedure on it. A lot of times what we'll do, there's really a couple flavors of ingrown nails. The most definitive procedure would be to go and actually cut down the entire aspect of the nail. And you can put a chemical in that stops that portion from growing back. That's the most definitive way. That's typically what I recommend for people if they've had multiple infections or just consistent pain. You can remove the entire nail. And again, both of those types of procedures can be done where you do the procedure and you let the nail grow back. There's no guarantee that that nail doesn't come back worse. There's no guarantee it comes back better. It may come back exactly the same. It may still cause you issues. So a lot of times, I usually recommend putting the chemical in to stop that portion from growing back as a definitive treatment.
What physical therapy exercises are recommended for bunions?
So a lot of that is going to depend on sort of what you have. So if you're somebody with a flat foot and tightness in your Achilles tendon, those two kind of go and coincide with each other as well. It's going to be more arch driven strengthening. So trying to be able to create an arch and sort of tip your foot into sort of supination rather than pronation. The other thing is going to be the ability to sort of pull your big toe away from your second toe. So a lot of people don't have great ability to do that. If you look online and you look up big toe exercises, you will see people that almost have a thumb for a big toe. They have very good strength and mobility to that. Now, again, this portion of that, this bony prominence is going to be there. You have the ability with physical therapy, if you have a flat foot or an equinus, tight Achilles, to improve those things in conjunction, if you use orthotics, to improve the positioning here. But again, this portion, this 19 degrees, is a bony problem that stems from the joint back here. And that is something that just isn't solved with anything conservative. There's certainly ways to accommodate that and the ability to, pull your big toe off of your second for you to, actively fix the positioning of your big toe. But it does not change this, relationship here between the first and second.
What tips do you have for purchasing arch supports?
It's a great question. Typically, I'd have to see people in clinic right away to be able to give them a good idea of what they might need. Just a general overview, I tend to recommend Power Step orthotics for most people. Power Step has, a good variety. I tend to not do a whole lot of custom orthotics. I don't personally cast or do any of that for custom orthotics. That tends to be a referral out to companies that do them, the molding and the fabrication of it and the modifications as needed. But Power Steps are great because they have a lot of different styles. They have good materials. They're well made. And they just have so many different variations now that they're almost custom. The types of orthotics that you can get most of these in low, medium, and high arch. You can get them in all sorts of different 3/4 length or full length. If you're in dress shoes or cleats, you'd be looking at something that's more of a 3/4 length. There's just so many different varieties, but Pinnacle for most everyday life, Power Step Pinnacle. And then again, if you're really flat footed or really lax and you've lost that arch, there's also a max version of that, which just has more stability at the heel and a bit more sort of control of the positioning of the foot.
When you get a spacer, how often do you wear it? Every night while you're sleeping?
No, it's the spacer is really again, it's a symptom control. It's not correcting anything. You're not really stretching out anything. It's there in your shoe for when you're walking to try to prevent how much prominence you have from that big bump and to prevent the big toe from rubbing on the second toe. Some people will develop some pretty, bad wounds between the first and second toe or even bad calluses because of the rubbing. The spacer really is there to keep the big toe off of the second.
Sometimes I feel like my sock is bunched up in my shoe, but it's not. What might cause that feeling?
That's a very common descriptor for a neuroma, which is an inflamed nerve that runs underneath the ligament between the heads of the two bones. But that is, yeah, a rolled up sock is a very common descriptor for a neuroma.
What is suggested for nail fungus?
There's really three ways to treat, well, four if you include removal of the nail. There's a topical that you can use. It hasn't been shown to be very successful. I usually tell people it's around 20% cure rate. And that's typically done daily. You basically paint on a lacquer daily. Once a week, you take it off with an alcohol wipe, and you do that for about a year. So for most people, I tell them if it's early or if there's different types too of fungus. There is something that's known as superficial white, which is basically a white staining of the nail itself. That and thinner nails tend to be more, have more success with the topical options. If you have a really thick nail with a lot of debris underneath a topical, I always tell people a topical is just going to be a year wasted doing that daily. Ultimately, a pill version, terbinafine or Lamisil, tends to be what is most common. That's somewhere around a 70-75% cure rate. Now, again, there's cure rate and then there's improvement. So I tend to recommend that for most people. That's once daily for about 3 months. Sometimes after that 3 months, we'll take a month off and then restart for 1 month. We still routinely get labs for that, liver function labs. Old literature showed that the medication could cause liver damage. That was only ever the case in people who had active liver disease or cirrhosis. So a lot of new literature and recommendations are not to even get the labs. And then really the third option is laser therapy. It's again not something that we offer, but it has been shown. Some of the earlier studies have shown upwards of 90% cure rate with that. It's an out-of-pocket cost. It's newer, so it's much more expensive. It's one of those things where if it's something where you either, we've discussed that a topical is not a great option for you. You don't want to add another pill to your your cabinet every morning, or you just can't have it for liver reasons. Laser therapy is the other option other than removing the nail. Removing the nail and letting it grow back in again doesn't guarantee that it's not going to come back. It may come back normal at first, but then the fungus can still set in and cause those changes. With any of them, you're treating the nail that comes in and not the current nail that's there. So there are no quick solutions for nail fungus. A great toenail, which is what tends to be disease for most people, that can take anywhere from 6 months to a year to grow out from start to finish. So there's really no quick way to treat it.
How difficult is bunion surgery if you have arthritis in your foot?
It depends on where your arthritis is. So we had talked about doing this Lapidus procedure. If you have arthritis in the joint back here, it's a little bit more rare. But if you have arthritis here, it's a pretty common symptom that you'll have pain here from the bunion itself and then pain back here from the actual arthritis. That's where a procedure like this would be a go-to because you can correct the bunion and you can get rid of the arthritic joint at the same time. If your arthritis is in the big toe joint, this isn't one that's listed here because it's a little bit different topic. But we can a lot of times fuse this joint, the big toe joint. Basically, that's done with cutting out what's left of the cartilage and getting rid of all the spurs that tend to develop on arthritic joints and then putting a plate over the top of it. That big toe then doesn't move up or down or side to side except for at your interphalangeal joint. But people tend to do very well with that. Pretty much anybody outside of Olympic sprinters do very well with a big toe joint fusion. It is one of the most common procedures we do in podiatry and honestly in foot and ankle in general. And honestly has one of the highest satisfaction rates. So if it's big toe arthritis, if you're younger, there are options to go in and just shave down, kind of clean up the joint to try to increase motion and shave off. You can see here, this would have had a shave as well. You can go in and just kind of clean up the joint if you're younger and you don't have a real large bunion and it's more arthritic type pain. But yeah, typically it's arthritis. You're either getting rid of the joint and you're fusing it and making it one bone, or you're putting some sort of implant in. Unfortunately for the big toe joint, the implants just haven't shown great success in literature. So I don't personally do the implants because for me, I always call those a staged fusion. So.
Did you say you have some questions that came to you as well?
Yeah, we got a couple I can go here. Tight muscles on the top of the foot get sore after walking for a while, something that just needs to stretch out. Doesn't seem to fit the issues you've described. Yeah, that again, it kind of depends on exactly where your pain is coming from. If you have arthritis on the top of the foot and you're getting increased prominence just from the bony overgrowth on those joints and what we would call osteophytes, sometimes those can irritate the tendons as you're walking. And can cause inflammation around there. And just in general, arthritic joints tend to swell more. So you can put more pressure just in general in the soft tissue on the actual tendons themselves. So without seeing you, it'd be difficult to give you a direct treatment. And then I do have another one. Does weight loss help keep bunions from getting worse? Not directly. Again, weight loss certainly can lead to things such as overpronation or flat foot. Again, you're putting a lot more pressure through tendons and ligaments, which can cause, stretching of those ligaments, can cause degeneration over time. And then again, if your foot starts tipping more into sort of a flat foot type position, naturally, if you look at the end of your foot and you start tipping into a flat foot, you're naturally putting more pressure on that big toe, and that's going to force it over and again cause issues. So while most bunions are hereditary in the sense that we see people all the time that'll have a bunion on one side and not the other. They've worn the same pair of shoes their entire life. We see kids with bunions all the time. But there are certain other factors that can lead to development and progression of bunions. But certainly weight loss wouldn't hurt, but it's not going to, I would say, fix the bunion by any means.
So Is there, you mentioned the neuroma earlier, is there treatment for neuroma? And
Yeah.
then after that, the question is some general recommendations for taking care of our feet as we age.
hmm yeah, neuromas have quite a few different treatment options. Typically, it depends on where your symptoms are and when your symptoms are. If you're somebody who's a runner and you've got a neuroma, it's difficult because if you're a forefoot strike, you do a lot of pressure on the front of the foot where that neuroma runs underneath the ligament there. Typically, it's something that's known as a metatarsal pad. Helps splay the metatarsals out a little bit and just take pressure off of the nerve that runs there. Typically, neuromas, we do corticosteroid injections. That tends to calm down the inflammation of the coating of the nerve. That tends to be where the pain comes from. Some things that mimic nerve a neuroma, and this is why we tend to get an ultrasound on these, is that some people, as we talked about with the Achilles with a bursa, you can actually develop a bursa in between those two metatarsal heads as well. And that bursa can basically fill space because it's just a sac of fluid. And that can be what presses on the nerve and causes those symptoms. So if it's a bursa specifically, typically we would try to inject that during the injection rather than just putting it on the nerve itself. There is surgery associated with neuromas as well if conservative measures haven't solved it. Basically, you're trading whatever pain or symptoms you have for numbness because the treatment would be to go in and cut the nerve out.
And then general recommendations for taking care of our feet as we age.
Yeah,
That'll be
there's
a
a
good
lot.
last
Yeah,
question.
there's a lot. I do a whole presentation on that later in the year. So I'll kind of hit a couple of points. One is daily foot inspections are important. A lot of people will have calluses, or you'll have what's known as like an IPK or a corn, basically a plantar keratosis. Um, Dry skin, fissures. These are all things that can quickly creep up on you and cause a lot of pain if you don't actively treat them initially. So having a good moisturizer for your feet, again, kind of going back to the zero drop and sort of cushioning portion. As you age, you tend to lose some of that fat pad cushioning on the bottom of the foot. So I usually recommend not going barefoot on any sort of, hardwood floor, tile, laminate flooring, anything like that. That tends to lead to a lot of pain and callousing potential for most people underneath the bony prominences on the bottom of the foot. So usually some sort of cushioning, shoe or slipper, or, they even make sleeves, like if we go back through these here, they do make sleeves like this that'll have this gel will just be the entire bottom aspect of the foot, um, just to kind of help cushion. The other thing is too is obviously with as you age, balance and falls becomes a risk factor. So you don't want to have shoes that have too much cushion. You don't want to step on it and feel like you're on a pillow. Um, you do want something that's got a nice wide sort of flat base to the shoe. Brooks makes a lot of good shoes in that sense. Again, the more cushioned it is, the more risk you are of that instability within the shoe itself. I always tell people as you age, this is something easy that everybody can adopt. Balance is a huge issue, and just strength in general as you age. So having some sort of workout or gym activity, some sort of strengthening exercises, that can be physical therapy. It can be, getting a trainer at the gym. It can be, just going with friends or family or whoever. The other thing that's very common that I recommend is when you're brushing your teeth, just stand on one leg for a minute on each side. Brush your teeth for 2 minutes, 1 minute on your right leg, 1 minute on your left side. And you can hold on to the counter so you don't fall, but it really does help. And it's something simple. You're standing there. Most people were either looking at our phone or staring at ourselves in the mirror. So, add a little bit of balance training and strengthening to your day for that. Um, it's kind of the main big points, but
Great.
yeah,
Well, thank you so much. We've taken us through the whole time, so everyone had
yeah,
really great questions. So if you could go to your last slide, they can see your number again
yeah.
if you want to make an appointment with Dr. Lind. And I'll take this, oh, it's kind of small, 608-501-6205. And you have the community ed email when you signed up, you got the confirmation email. You can respond to that as if you need me to connect you to him. The other thing I wanted to mention is we have a foot clinic um, where we have a foot tech who, for a cost of $30, she does foot inspection, toenail trimming, foot massage, some foot care education. That's at the Community Health and Wellness Center, and we're out at the corner of Highway 51 and Highway B. So the number to schedule that is 873-2332. I don't know if you want to say anything about the foot clinic, Dr. Lind.
Yeah, so the foot clinic has been a really big help to the area. The Our practice currently is set up more of a musculoskeletal injury, deformity, surgery type. Again, we see everything from surgical and non-surgical, so happy to see anything that comes in. But when it comes to nail care, so if it's purely sort of nail trimming or even just callus debridement, if you're on Medicare and most insurances, they have very specific guidelines about what they cover and who they cover for that. And just not being able to reach your nails is not a reason for them to cover you. So what ends up happening is we get a lot of folks that come in, and they either just don't meet requirements, and then we have to tell them, hey, we can't do it. Otherwise, you're going to end up getting a big bill for my portion of it. Or we can kind of bypass all of that and go straight to the foot clinic. Again, it's $30 out of pocket, and rather than insurance covered. If you are diabetic with peripheral neuropathy, prior amputation, poor blood flow to the feet, things like that, you would be covered. But for the most part, we try to keep those types of things out at the foot clinic. But they do a great job out there. I have a lot of folks that see both. And certainly, if you have something out there that they feel needs to be seen, they're very quick to refer back over. So
Yep,
we do work pretty closely with them. But
yep. Yeah, and the number again is 873-2332. Dr. Lynn's number, 608-501-6205. And again, you can go to stoughtonhealth.com. You can find all the services, and I think that will do it. So thank you,
yeah,
Dr. Lind, and thank you everyone for joining tonight.
yeah. Thanks for coming on, everybody.